It's 4 p.m. Italian time, so it's time to say, as always, benvenuti, which in Italians indeed means welcome, starting with the image of the spectacular Italian pavilion at the Universal Expo that, as you can see, is made by a roof created with 3 upside-down boats, a metaphor of the journey around the world we all do, that of course in this time is quite challenging, but that hopefully soon will lead us to be together again in person. And in this case, of course, we mention the opportunity of the Universal Expo Dubai, where there will be more than 190 countries, each and every one with its own pavilion. So while we are looking to see all the nations' pavilion structures, you can see the representation of the 3 related to the countries for which we are providing today simultaneous translation, so Russian, English, and Spanish. Today we will provide also international CME credit certificate, so just remember to pick up your language and then to request the certificate at the organizing secretary after the webinar. Everybody's welcome to make questions in whatever language into the question and answer box. So not in the chat, but in the question and answer box. They will be answered live, and if not, in written forms based on the time allowance. We deeply thank all the ones involved in this online educational path that is leading us toward the Universal Expo and the Winter meeting in 2022, next February, where we will surely connect huge experts to properly inform patients, in particular against the venous lymphatic fake news. As always, it's not just where you're going, but also we are traveling with. So we'd like to deeply thank the ones who have already joined this online educational path, so the Achieve Project Companions, as well as the VWin China, with a particular mention to Professor Jin Song and Professor Shenming Wang for the spectacular teamwork, of course, together with Professor Chi. Today we move forward with a new section, the one dedicated to the pelvic venous disorders online project indeed. And since the topic is of key, paramount importance, as we know, it has been defined a forgotten disease. We know that we must put the maximum care in this education, and for this, we asked the biggest expert on the field, Professor Zaza Lazarashvili, and the Georgian Association of Angiologists and Vascular Surgeons to be travel mates in this educational initiative. But as always, all the world is involved with the huge figures, starting from Professor Wasila Taha from Egypt, and all the ones you see reported over here, we will present one by one, who also contributed with extra educational material you can find in the platform, together with the live presence of a truly stellar faculty that today is with us. Nothing would have been possible without the unbiased support of Alpha Sigma, and a particular mention goes to Alpha Sigma Russia for providing simultaneous translation in Russians as well. At this point, as always, we welcome a word from our best travel mates and also family members for me, Professor Bottini and Professor Che. And since Professor Bottini is having some travel issue in terms of connection, here is his message.
Dear all, as always, thank you to all the ones joining our educational teamwork, with a special mention to Professor Lazarashvili, the colleagues and friends of the Georgian Society, as well as all the gynecologists co-working in this initiative with us. Y muy especialmente a la comunidad latinoamericana que siempre ha respondido fielmente a esta propuesta educativa. Hoping you will enjoy the outstanding scientific program. Esperamos que disfruten esta propuesta educativa. Muchas gracias. Thank you. Dear all.
We deeply thank the translators who have been so cool in translating at the same time both English and Spanish versions. So congratulations to the simultaneous service. And now congratulations to Willie for being the best example of professionalism and also of friendship you can find along the way. So Willie, the mic is for you now.
Well, thank you, everyone. Good morning, good afternoon, good evening. And here we go again. 各位朋友们、同道们，大家好。如果有任何问题，请在我们的 Q&A 箱，我们会尽量为您答复。谢谢大家。Thank you.
Thank you so much, really, always for your effectiveness. And now it's our huge honor to introduce the project leader, the one who started this with us, for which we deeply thank his teamwork together with the one of the Georgian Association. Zaza Salvatore Lazarashvili, the mic is for you.
Thank you, Sergio. First of all, I also want to ask some words in Georgian. Didi Madloba, Sobalas, James Collectives. Didi Madloba, James Collectives, Aesthetic, Swingalet, all these organizations. Dear friends and colleagues, it is a great honor for me to present the pelvic vein disorders online project aimed at raising the awareness of pelvic vein disorders. The project, on the one hand, is part of the pelvic venous disorders awareness campaign, which was declared during the International Unions of Phlebologists chapter meeting in 2019. And on the other hand, is part of the Weaving Foundation's largest project called the Road to Dubai 2022. I would like to deeply thank you, my friends Sergio, Oscar, and Willie, for the great work, as well as all the speakers, discussants, and guests of honor. I think that this project will help to increase awareness, as well as bring closer the views of doctors of different specialties. I am glad to be able to open the webinar site named for Pelvic Venous Disorders online project. Thank you very much.
Thank you so much to Professor Zaza Lazarashvili. We didn't mention before a fundamental step forward in the online education activities WIN has been doing for the Road to Dubai, that is LATAF, the synergy between Latin America and Africa made possible just thanks to the teamwork and professionalism of Professor Taha, Professor Bishara, Professor Bottini, and Professor Simkin Carlos. So it is right that it is Professor Taha, our Cleopatra of phlebology, to introduce the first guest of honor, who is another innovation, let's say, in our webinars, because we really look forward for team working with the OBGYN ward, so the gynecologist. And for this reason, I will now pass the mic to Professor Taha to introduce our eminent guest of honor of the day.
Thank you, Professor Gianisini. It's a true honor to be today among such experts of the pelvic venous disorders. A new educational initiative, very bright idea, and another relay to the road to Dubai 2022. Congratulations, V-Win, Sergio, Oscar, and Willie. And I'm truly honored to introduce Professor Hassan Ghaffar. He's really a great icon of the field, an expert in Egypt and the whole region, a perfectly knowledgeable professor, an evidence-based professor. And unfortunately, due to an emergency, he won't be able to join us, and we do have a recording for his speech. Now we will listen to the speech of Professor Ghaffar from Egypt.
Thank you so much, and we will have the honor in the last webinar of February 14 to have him live with us.
Morning, good afternoon, good evening, depends on from where are you watching us. I'm Dr. Hassan Ghaffar, talking to you from Cairo, Egypt, representing Egypt and the whole Africa. It is my pleasure to be with you today. I'd like to thank Dr. Wasila and Sergio for this invitation to be with you with the V-Win Foundation and with the POP, the Pelvic Venous Disorder Online Project. This very nice initiative, and it's very important to raise the awareness for the pelvic venous disorder and to raise and promote multi-speciality involvement for this disorder. Many of our patients suffer from pelvic congestion syndrome or pelvic venous disorder, and we need to help them. We need to work together as a multi-speciality team. We need to find answers for the question to help them be relieved from their pain. I'm sure that this foundation and this project and this webinar will go through all things related to the pelvic venous disorders and will help many of our patients go through their pain and get relief and answers for many of their questions. Thank you very much. I'm leaving the floor now for Sergio and for Dr. Wasila. Thank you.
And we thank Professor Hassan. As always, we take off from Egypt, that is the cradle of culture, as always. So once again, that's where we start with the project, and we start to fly all the way to France, starting with a really eminent figure, Professor Jean-François Hull. We all know him. He's our anatomist around the world. He's coming from the Paris University. He's author of a recently published book that I would define as a must-have book, and I'm sure you will enjoy greatly his talk. Khaled, you can play the video.
As an introduction, I would like to highlight important facts. The pelvic and lower limb constitute a functional and anatomical unit, and there is a tight functional relationship between the gonadal, hypogastric, spine, pelvic, and saphenous system, because they are related, they are connected with complex anastomosis. So first, a reminder of the pelvic network and its multiple connections, which are the derivative roots of the pelvic veins. And you can see here on this image that you have a lot of vertical connections, first with the gonadic veins, mainly the left gonadic vein, with the iliolumbar vein upwards to the azygos system, and also to the suprarectal vein. The second important point are the horizontal connections, and these are inside the pelvic area, and you can see that you have two different kinds of connection: the parietal connections, mainly anteriorly the vesical plexuses, plexus of Santorini in the radius space, and posteriorly the sacral plexus. But there are also a lot of connection in the visceral part, uterine, vaginal, and then obverse ligament. These are better seen in this slice, which is showing very nicely the visceral connection from left to right in between the organs. You see in the bladder, you see the uterus, and you see the rectum. The posterior anastomosis are shown here. They are the sacral plexus, and you can see that this sacral plexus is connected here in the internal vertebral plexus here in the spine. Here, these plexus, which are very important at the posterior area, are very nicely shown on this old image. Anteriorly, you have also a lot of anastomosis. They are shown here in green. They are the vesical veins, which are forming a plexus that is called Santorini plexus on the anterior part of the bladder, in the rhesus space. They are shown more easily here, and you can see the very important plexus, which is located anteriorly to the bladder here. So second, you have other connections, which are that we call the higher connections, and these are connected with the thoracic, caval, and azygos system. And mainly, they are made by the plexus veins of the vertebral venous plexuses inside the spine. This is a big venous system in the organism. You see that they go from the coccyx to the occiput, all along the spine. Inside the spine, you see here very nicely these big veins which are making a plexus and which are connected at each level, at each foramen level of the spine. This venogram is showing also very nicely that in case of a thrombus in the vena cava, you have a large development of the collateral circulation, mainly by the ilio-lumbar vein and these important plexus inside the spine. And you can see in this image, which is a corrosion, anatomical image, a corrosion, very nicely, the very important plexuses which are located inside the spine. This is a three-dimensional representation of the same plexus inside the spine, connected with a caval system, and you see, and with a plexus and pelvis system. So, as you can understand, vertebral venous plexuses offer a very important derivative route in case of vena cava or iliac occlusion. And this is important in a clinical practice because they are explaining a sciatic pain that we could see during thrombosis of the vena cava on the iliac or during pregnancy due to caval compression. Why? Because, as you can see on this drawing, you have a lot of veins which are surrounding the roots, the nerve roots on the lumbar area, and these veins are surrounding the nerves, the roots, and in case of dilatation, in case of collateral circulation, they are dilated and they make a compression of the roots. So now let's say the lower connection, which are the pelvic connection, and we have to keep in mind that these are very common. They are making pelvic escape points from the pelvic to the lower limbs. As you know, Claude Franceschi describes these pelvic linking points, and you have here the inguinal point, the obturator point, the perineal point, which is the most frequent, and also the gluteal, superior, and inferior points. They are also located on the other side. So, why are these linking points important? Because they provide a lot of reflux towards the lower limbs responsible for varicosities. And you can see that you have different routes. You have the route of the left ovaric vein by the renal vein and by the round ligament, which is the eye point. And you have also the classical leaking points coming from the hypogastric system, which are the internal pudendal, P point, obturator, O point, and superior and inferior gluteal, G point. And you see they are very common. So some example of these, The P point, you can see a clinical image here. There is a perineal network, and you see this is transmitted by a reflux of the internal pudendal vein, which is shown in green, and this vein is going through that we call, here you see with the nerve and the artery, it's going into the Alcock canal, and so emerging in the inguinal and the perineal area. And you can see the image of the phlebograms on the left. Another case report showing varicosities of the grease-saphenous vein territory. As you can see here, it's not fed by the inguinal, by the grease-saphenous vein termination and the inguinal area, but by the P point. And the P point is transmitting the reflux by this network to the grease-saphenous trunk at the side level. And you can see here that you can follow, you can see the Alcock canal, and you can see the reflux going through the obturator vein, and also together with the pudendal vein here, and this is feeding the varicose veins of the perineal area. I show you an animation inside the body to understand this better. You can see here in the front, you can see the pudendal, internal pudendal vein. We are in front of the femoral vein. You can see the connection, the re-entry in the femoral vein and the saphenous system. And you can also follow the origin of this, which is the internal pudendal vein, and together the obturator vein. And we see more precisely the sacral plexus, the dilated hypogastric vein, and the importance of the dilatation of the pelvic veins. See here the obturator vein going through the obturator hole. And what is the origin of this? It is an hyperpression in the hypogastric vein and dilatation. And you can see here on the top a groove on the vena cava. This is coming from a compression by the right common iliac artery. And we call this a pseudo-May-Turner syndrome. And you can see when you can modify the threshold, you can make the artery appear, showing very nicely that the artery is compressing, is creating a groove on the vena cava. So now some words about the GI point. This is well known as the varicose veins of the seat of the ischiatic nerve. And this is a clinical presentation. You have a varicosities of the calf. The small saphenous vein is completely normal, and this varicosity is not in the midline, it's a little bit in the lateral area, and you can see that if you follow the reflux with a probe, you lose it in the thigh. Why? Because the leaking point is very highly located in the inferior gluteal vein, you see, and you can see that you have a lot of veins which are surrounding the ischiatic nerve. So you see the ischiatic nerve only because it's surrounded by a plexus or the dystrophic venous network coming from the inferior gluteal vein refluxing. And this is an animation showing the same. Very nicely, you see the surrounding veins, which are highlighting the root of the ischiatic nerve, which is not shown by CT. And you see the femoral vein. I will end this talk with just a word about the pelvic vein of the male. We investigate them by cavernous CT because it's impossible to inject them by the lower limbs. And you see that you have the vesical veins in blue, the obturator vein in green, and the pudendal, interior pudendal vein in light blue. And these are the draining here, the dorsal vein of the penis. And this is a case of deep cavernous leaks. Investigation is done during impotence. Just a small thank you very much for your attention. If you are more interested in venous anatomy, you can have a look at my atlas book.
And here we deeply congratulate Professor Hull for truly a spectacular lecture. Francois, you're with us, right? So unmute yourself because we have a word round to do with you now of questions. Can you hear us? And unmute yourself, please, Jean-Francois. Can you hear us?
Yes, of course.
Yes, that is great. So let's start as always with the word round in 10 minutes, starting from Mexico with our dear friend, Professor Javier Serralde, who is unfortunately having technical issues. But this difficulty is an opportunity for me to make a question to you. I look like a little bit like him as a haircut, so maybe I can take his place. So we published together also with Professor Tessari and Professor Antignani a paper talking about the foam treatment of the pelvic leaking points. And we were showing that there is an opportunity when you have a vision analog scale in terms of symptomatology less than 5 to have some good results. In terms of anatomy, Jean-Francois,
yes,
is there some anatomical aspects that is preventing a treatment of the varicose veins in the leg to be effective? Are there some anatomical barriers we should be aware of, or is it just a normal channel going from the lower limb toward the abdomen?
no, it's normal connections. It's normal connection. But in case of oppression of compression, they could be in hyperpression and though reflux downwards to the lower limbs.
So what is your vision in treating, in specific cases, of course, the varicose veins at a starting point in mild cases? Is it something that makes sense to you, or?
It's complicated, but anyway, first you have to come back to clinic. And as you know, there is a new score done by Mark Meister because it's very complicated problems, pelvic congestion syndrome. So for this, you need to study very carefully the clinical problems, to relate them to the abnormalities, to have hemodynamics, a good hemodynamical investigation, and lastly, to have good anatomical information, because this is very complex. And if you miss something, you will not treat correctly. So, and in particular from the reflux from the left ovaric vein. So you keep in mind that it could come from the left renal vein. It could come from different things, but anatomical information and then good hemodynamic investigation is really essential if you want to treat.
Thank you so much. Now we fly all the way to Russia, and it will be our project leader, Professor Lazarashvili, to introduce the key opinion leader. Zaza? Unmute yourself, Salvatore.
Sorry. I want to introduce Professor Evgeny Shaidakov, my old friend, and he's from St. Petersburg University and chief of St. Petersburg Venus Forum. Evgeny, I just look.
Thank you very much, my dear friends. Nice to meet you again. Dear Jean-Francois, thank you very much for a fantastic presentation. As usual, one of the Russian famous surgeon, Nikolai Pirogov, many years ago, told a surgeon should deal with the anatomy not as anatomist. Let the anatomist study human cadaver to the minute detail, but even then, he will never be able to attract students' attention to those aspects of the anatomy that not most significant for the surgeon are of no consequence for the anatomist. What's your opinion? What you do about it? We know much about nutcracker and May-Tuner syndrome. Are there any little known particularities of pelvic venous anatomy which account for pelvic congestion syndrome? Thank you very much.
Pelvic venous anatomy is very complicated, as you understand, due to the connections. There's so many connections from left to right and top to bottom. So it is very, and the variations, like in all venous system, are very important. So if you don't know exactly the anatomy, it's difficult to investigate and difficult to appreciate what happens really in the body. That is a problem. So it's very complicated, and of course investigation by duplex color is very nice, but it is complicated. It's not very easy, it's simple to do, and in more cases If it seems to be complicated, you need some more investigation, that is CT venography or catheterization of the, and this is also the way to treat. If you have a catheter inside the veins, you can put a coil, you can put foam, you can put glue, and this is the way to investigate, to be sure what you have, and to be sure to occlude all the feeding trunks feeding the pelvic reflux.
Thank you so much, Jean-François. Thank you so much, Eugene. We fly all the way to Argentina, and since the next key opinion leader is part of the family, it will be indeed Willy introducing him.
Well, indeed, this is a huge figure from Latin America, not only a friend, but a family to the VUM Foundation, Professor Roberto Simkin.
Unmute yourself, Roberto.
Roberto?
Unmute yourself.
Yes, of course. Can you listen to me?
Yes.
Okay.
Good.
Yes. Congratulations, Professor Ull. Excellent your presentation. I like very much, especially the pictures, and your work is excellent for the student, for all together. Clear, very, very clear. Only one question, a simple question. In the pelvic reflux, who is more important, the anatomic situation or the size of the vein?
The size is just a reflect of what happens, but the size of the vein is also not so important. But what is important is the development of the network. If you have a collateral network with big veins, that is a signification of an obstruction, because the flux of the iliac or big flux has to go up, and you need to have a collateral circulation. So big dilatation of the veins is a sign of a collateral circulation of a very important obstruction downwards. But I think the anatomy is not so important. You have to go to the hemodynamics more, because it's the hemodynamics which are the final problem. Anatomy is just a way to explain how does it work.
Thank you very much, Dr. Ull. Thank you very much, Dr. Giannesini, to the kind invitation for me. It's a good pleasure to stay in this very important symposium to all the world. Thank you very much.
Thanks to you, Roberto. You truly are the giants we are walking on the shoulders of, so thank you. And we now fly all the way to China. Of course, in China, it's really late. So for Professor Wang, I have a question over here, Jean-François. She's asking, what are the indications for scanning the pelvic venous disorders by invasive methods?
Oh,
so
that's a good question,
yeah.
And complicated question. It depends of a lot of things. Once again, I think we have to score and to better classify the pelvic congestion syndrome, because it's a lot of things together which are not the same. So if you know exactly the origin of the reflux, if you are sure of the relationship of the pain of the problems with the anatomy and the hemodynamics, I think you should treat. You can treat, because some female have so much pain, and they go from a practitioner to another, and there is no diagnosis, because it's nobody knows that it could be of pelvic of venous origin. So to have a good investigation, to identify the venous problem, and to assess it correctly, you will go to a treatment which is a direct treatment. Could be foam, but mainly could be by catheterization of so many pedicles and occlude them, because once again there is a lot of connection. If you occlude just one single pedicle, you won't have a good treatment. So this makes things difficult, and you have a specialist, international radiologists doing that very well now, as you know, and they are very efficient if they identify the linking points and they occlude them.
So thank you so much, Jean-François, and I'd like to deeply thank once again Professor Scheidak, Professor Simkin, and Professor Wang for being the key opinion leaders of this round. As you know, Jean-François, now it's time to join the audience. So let's have a look at the question that got more likes. It's in French, in your honor, very probably. So it is from Céline Bordelot. What is the best ultrasound view or technique to explore the sciatic nerve varices? We could address this also to Wasila, of course, but it's your time now.
That's also a good question, because it's not possible to correctly investigate the sciatic veins, the sciatic pelvic, the varicose around the sciatic, because it is inside the thigh, very deeply inside the thigh. There are small veins. So for this, it's complicated, but I think the only way is to make a CT or MR angio. And I showed you the image. Is very. I work with my friend in Brazil doing that very well. He has a lot of cases. If you look for them, if you identify those veins, you will have them. You will identify and diagnose them. But by echo, it's very complicated because it's a limit of Vasilia. You have something to add for this?
Bonjour, Jean-François. J'ai bien aimé votre présentation. It was perfect. Thank you very much. I will go for the posterior aspect of the thigh. And if there is really considerable varicose veins around the nerve, you can, as you know very well, Jean-François, the nerve itself, it's very echogenic, and you can see the nerve by echo. It's a bit deep. You can just adjust your depth. And at this, by B mode, and only B mode, you can see the small varicose veins around the nerve like echolucent circles. And you put your color flow, you put some maneuvers, augmentation, and then we give the reflex around the nerve.
I agree. If you look for them carefully, you will, with a good probe, you can see that. But the problem is the feeding points in the pelvic area upwards. So to have all the system, all the anatomy of this, the full investigation, full information, I think you should have more investigation.
They are really considerable, yes.
Thank you, Vasile.
That is great. And having two experts like you over here, what do you think about the Ricci sign? It is a sign for which you can move the probe and you see the surrounding tissue that is basically refracting while the nerve remains the same. Do you have experience with that maneuver, or do you consider it valid?
I think Vasila has, yes. If you move the angle of the probe, the nerve will appear. And
you just you just move a little bit the probe and you see that the surrounding is moving.
The small circles move, but the nerve it's still.
That's another technique we could talk about.
With the color flow, because only the veins will be filled with the color flow, but not the nerve. This is another tip.
This is the reason why we need to go back to in-person meetings, to go to the coffee break and talk about these things. That's why we cannot go on with just the online. So thank you so much once again, Professor Ulen, for the contribution to our Cleopatra of the ultrasounds. And now it's our time to move forward. I'd just like to thank Swat Doganji, who is a huge expert who will join us at the next initiative. They made a very good comment in the question and answer box. So we take this chance to remind everyone you can make questions in the question and answer box, and they will be replied in the following days also. So we will ask Professor Hull to reply to these questions by emails in the next days. And so we now move to the second part, deeply thanking once again Professor Hull, and deeply thanking once again our project leader, Professor Zaza Salvatore Lazzarashvili. Needs no introduction. We will enjoy his talk about pelvic venous disorder definition. So I will ask Khaled to play the video and then we will have him live. Khaled, thank you.
Dear colleagues, current definition of pelvic venous disorders is not clear and requires discussion with large multidisciplinary involvement. I have not any disclosure. Some historical facts. The pelvic vein anatomy was first described in the beginning of 19th century for Brecht and Bock. Brecht described pelvic varicosities in 1857 and named as tubo-ovarian varicocele. Howard Taylor in 1949 introduced term pelvic congestion fibrotic syndrome, and at last in 2009 was published vein term transatlantic interdisciplinary consensus document where the term pelvic congestion syndrome was adopted. However, other terms like chronic pelvic pain syndrome, female pelvic varicocele, pelvic venous incompetence, pelvic varicosity are often used in literature. By the view of Champaneria, the diversity of terminology is linked to the multidisciplinary nature of disease, because interventional radiologists more likely to emphasize the aspects of the venous system, vascular surgeons highlighting the relationship with varicose vein, and gynecologists focusing on pain and pregnancy association. According to the vast majority of well-known experts, today's official syndromic nomenclature does not correspond to the reality. Mark Meissner told that the current state we are in is this alphabet soup of pelvic venous disease. We have this group of syndromes, nutcracker, pelvic congestion, May-Turner, none of which make a lot of sense. Mark Whitley states that pelvic congestion syndrome is probably one of the worst names for a medical condition, and Kate Gibson notes that a lack of standard terminology has hampered our understanding of the best practices for treating these patients. In the consensus document of International Union of Phlebology about diagnosis and treatment of pelvic congestion syndrome, the introduction states that the use of the term pelvic congestion syndrome for this medical condition is recognized as incompletely characterizing the full pathophysiology and presentations of disease of pelvic venous system. However, since the final agreement on the optimal nomenclature still has not been reached, the consensus document task force members decided that the document should contain the term pelvic congestion syndrome, which is included in the recent International Classification of Disease and vein term transatlantic interdisciplinary consensus document. International Pelvic Vein Working Group identified three main tasks: to establish disease definitions for pelvic venous disorders, to develop discriminative tools for classification, and to develop disease-specified quality of life and outcome tools. As you can see, working on modern terminology is not as active as on other tasks. Highly characteristic is the fact that was observed in 2019 in Krakow during WIP chapter meeting. The scientific program included 21 papers on pelvic vein disorders and used 6 different terms that you can see on this slide. I asked 23 well-known experts to express their opinion, and 18 of them supported the term pelvic venous disorders. Officially so-called syndromic nomenclature is represented by 3 main syndromes: pelvic congestion syndrome, primarily developed due to reflux, and the 2 main types of compression syndromes in which pelvic congestion is secondary. Due to the urgency of the problem, we decided to present our proposal on the definition of pelvic vein disorders and related terminology, according to which pelvic vein disorders are a term that combines all the chronic pathology of the pelvic veins with the development of venous hypertension and abnormal retrograde flow in them. The development of pelvic venous disorders is mainly caused by two pathophysiological mechanisms, reflux and obstruction, or a combination thereof. Also, the development of pelvic venous disorder can also be caused by the presence of venous malformation in the pelvis. Reflux that can spread above the or below pelvic escape point own with well-known term pelvic congestion syndrome. Obstruction can be endo or extraluminal. Endoluminal obstruction can be post-thrombotic or non-thrombotic, caused by several structures like spur, fleboids, etc. In turn, obstruction can be caused by dynamic and static compression. Dynamic compression group includes left renal vein and iliac vein compression subgroups, in which well-known compression syndromes are considered. Static compression refers to conditions where pressure on a vein is permanent from a different structures, pelvic mass, fibrosis, artificial tissue, etc. We think that such differentiation of pelvic vein disorders are actual and correct in choosing of right treatment strategy. Will easy to understand it for doctors with different specialties and will greatly simplify the relationship with healthcare indemnity organizations. We are open for future discussions and wait your comments and notes. Thank you for attention.
And we deeply thank our project leader. We ask Khaled to stop sharing so we can start the word round from my neighbor and dear friend and leading figure, Professor Antignani Pierluigi, President of the International Union of Angiology, and also author of the last UAP consensus document. Pierluigi?
Yes, thank you for invitation. Thank you, Zaza, for very interesting presentation, very complete presentation, and congratulations for this. The question is, you know that it's very important to define correctly the hemodynamic condition of patients to establish the adequate treatment. What is, in your mind, the best method to evaluate the pelvic venous disorders and discern the pelvic congestion syndrome from nutcracker or Metters syndrome?
Unmute yourself.
Thank you, Pierluigi, for the question. Indeed, the hemodynamic condition is individual in each case, and the correct evaluation of hemodynamic situation is a really prerequisite for the effective treatment. According to your question, in case for differentiation is pelvic congestion is primary or secondary due to obstruction, I think the clinical evaluation, detailed clinical evaluation, and complete ultrasound examination complex is enough for the diagnosis for differentiation. Is it primary reflux or secondary due to obstruction? Of course, other methods like some cross-sectional methods, CTV or MRI, venography, IRUS, they are for the differentiation, how to choosing the correct strategy of the treatment. It's my answer on your question.
Thank you so much, Zaza, and thank you so much, Pierluigi.
Thank you.
and we can fly to the homeland of this initiative, so Georgia. It's my huge honor to introduce Professor Bokuchava Mamuka, who is a friend I met when I was there, a country I really invite you to visit, wonderful Georgia for real. Mamuka, the mic is for you.
Hello. Do you hear me?
Yes, we can.
Thank you so much. Thank you. Dear Sergio, dear Oscar, Willie, and Zaza. First of all, thank you, Zaza, for your very nice presentation. I would like to thank you very much for giving me opportunity to take part in such a very important project as an expert. It was a big, great honor for me to be in working group, which made a consensus document for pelvic venous system disorders management. And as Zaza mentioned in his presentation, I was in group with 18 persons who supported definition pelvic venous disorders, and the same position I have yet. About my question is from clinical practice. Not very rare, we have a ileocaval obstruction in patients from childhood period, especially after central vein catheterization, mainly in the femoral vein. And manifestation of symptom of pathology begin in women on delivery or postpartum period. Meanwhile, the symptoms are the same severity from the pelvic and lower extremities zone. And my question is, what do you think in clinical practice? How can we formulate diagnosis? So in the first place, pelvic or lower extremity pathology definition. Thank you so much again.
Thank you very much, Ramuka. This is really problematic patients with masctopic disorders of venous flow. And I think because the pathognomic cause of this situation is mainly on femoral vein, the first diagnosis of complex diagnosis, the first must be the femoral obstruction of femoral vein. And also the endoluminal, as I show in my presentation, endoluminal obstruction of iliac veins and secondary pelvic congestion must be included in the complex diagnosis.
Thank you.
Thank you, Mamuka, and thank you, Zaza. We now fly all the way to Japan, and it will be Professor Chi introducing the next speaker.
Now we have our good friend to VWIND, Takashi Yamaki. Professor Takashi Yamaki, is Takashi giving us a video?
Yes, because it's really late over there, so we have his video ready.
Thank you, your nice presentation. I really enjoyed your talk. Pelvic venous disorder remains a diagnostic and therapeutic challenge and has a significant impact on a woman's quality of life. In the past, much of the literature describes this classic ovarian vein incompetence as a main mechanism for pelvic venous disorder, but now venous compression of the left renal vein and left common iliac vein is being increasingly recognized as a factor leading to the ovarian and internal iliac vein reflux, respectively. When evaluating a patient's clinical history, it is necessary to differentiate between the reflux and obstructive patterns of pelvic venous disorder to understand which symptoms are affecting the patient the most. Therefore, it is clear that standardized tools and measures are needed to better understand pelvic venous disorder. So my question is, does your company develop standardized tools and measures for classifying pelvic venous disorder like CUAP classification? Thank you for your excellent presentation.
And we thank you deeply, Professor Takeshi Yamaki, and all the Japanese friends who have contributed as well to educational initiatives along the last year together.
Very actual and very important question from Takashi. As I understand, he means the International Pelvic Vein Walking Group, which started working in 2017. And from 2018, we are working, we were working on pelvic vein disorders modern classification, which was introduced by the Mark Meissner and Mel Rosenblatt. And the name of this classification is S3P. It's some acronym of symptoms, varics, and physiology, pathophysiology. And as I know, it's in the press, and soon will published in 2001. And it is the real discriminative tool for pelvic vein disorders classification. And it's a very elegant and very informative tool. It's already created.
Thank you so much. Willie, please introduce us the next keynote speakers all the way from Bolivia.
Yeah, next we have a frequent guest to the VWin online project, Professor Luis Valario. Luis?
He was here.
Yes.
Maybe okay, here you
are. Professor Zaza Lazarashvili, congratulations. It's very, very important considering the correlation in between pelvic lower limb venous disorders and the classifications. I wondering if we can consider it, use it like a universal consensus, help us to give a definition in the diagnostic. We have the SEAP classification. I think we are in one step closer to make worldwide together one type of classification. What do you think about what we can do to put all together our system of diagnosis?
Thank you for this question. First of all, I must to note it that presented same of the disease which was in my presentation. This is not classification. This is only the logistical stem of the terms which need future definition. Modern definitions is totally, I propose the definition of pelvic venous disorders. Of course, I finished my presentation with like announcement of future discussion, and it's really possible to make the classification. There's two aims: to make the modern nomenclature and to make the modern classification. Modern classification of pelvic veins is done by the pelvic vein working group, SVP classification, and also the Professor Whitley also proposed the more easy for clinical use classification. And I think that it's difficult but possible to do some combine of the classification with, to involve all the different clinical situation in one. I think it's difficult, but it's possible. But another question: how this classification will be easy to introduce in clinical practice, because it will be difficult for the doctors of different specialties, medical specialties. It's my opinion only. But
thank you so much, Zaza. Thank you so much, Professor Villaroel. Thank you so much also to Professor Antignani, Professor Bokuchava, and Professor Takashi Yamaki for being the keynote speakers of this session. Now, Zaza, it's the time for the audience. And the best question in terms of votes is Jan Schweritz. In which cases could be appropriate to treat pelvic leaks with foam sclerotherapy? More or less what we were discussing before with Jean-Francois. Leg valvular varicose veins coming from pelvis, diameters of varicosities less than 4 or 5 millimeters, and lack of pelvic pain could be good case for sclerotherapy. Again, this is what we published with Pierluigi also and with Lorenzo Tessari in terms of VAS and caliber. So what is your comment on this, Zaza?
Yeah, so it's mostly, I think, the question to you and to Lorenzo.
Yeah, and well, of course, these are just preliminary data, but what we demonstrated is to have a careful assessment of the eventual need of going to a second level diagnostics, and at the same time to consider the symptoms. What we demonstrated is that with 3 shots of sclerotherapy, you could have in 60% of cases a good result in also 4 years of follow-up. So it is a preliminary data. I think more evidence is needed for sure. Also, because I don't think a caliber is really the answer. We should talk about hemodynamic load and proper investigation. So these are just preliminary data, and this is the reason why we are throwing this project, because there are many questions to be answered. So every data collection properly done is welcome, I'd say.
Yeah, I have a short comment again to note to all participants that presented STEM is not the possible classification of disease. It's only the stem of nomenclature, modern terms of pelvic venous disorders.
Thank you so much, Zaza. We'll see you later because, of course, we will wrap up the session. Now it's a fundamental moment because with this project, we are trying to gather together OBGYN ward, so the gynecology ward, and also the phlebology ward. And we have a sort of godmother in our dear friends, Aleksandra Jakurowska-Kaczorowska from Poland, because she's indeed both a gynecologist and a vein specialist. So now Khaled will play the video now, and after that we will meet her in person. Khaled?
Ladies and gentlemen, I have a pleasure to talk about gynecology awareness and clinical assessment in patients with pelvic venous disorders. At the beginning, short reminder about pelvic venous circulation, which consists of 4 interconnected venous systems, that is both ovarian veins, left renal vein, iliac veins, and superficial veins of vulva and lower limb. These veins form 3 venous reservoirs. So the 3 trunks form a single ovarian vein, which on the left side drain into renal vein, and on the right to the inferior vein cave, and in 10% to renal vein. An average diameter is 5 millimeters. It drains from the internal genitalia above the cervix and forms anastomosis with other visceral venous plexuses. There are a few possible variations in number of internal iliac veins. The most common is type 1. In about 50% of cases, it drains into ipsilateral common vein, and pudendal, obturator, and gluteal tributaries have their origin outside the pelvis. The incompetency of this vein, which may be primary or secondary due to compression or post-thrombotic changes, may cause pelvic venous disorders. We have to remember that in deep veins, the number of valves increases from cranial to caudal and are found only in small to medium-sized veins. Only 10% of internal iliac veins have valves, and in ovarian veins, they are mainly in the distal third. 15% of ovarian veins do not have valves on the left side and 6% on the right side. Although 90% of patients have no valve in internal iliac veins, Not all of these patients will develop pelvic venous disorders. There are very little research into why women develop this disease, and none of the studies have been replicated. One of the most important predisposing factors, of course, pregnancy, due to hormonal changes, increased blood volume, increase the capacity of ovarian vein during pregnancy up to 60 times, and venous compression by enlarged uterus. The reflex pattern analysis has shown that the left ovarian vein and right internal iliac vein were the most commonly involved, and in more than 50% of cases, it was combined reflux. Pelvic veins are connected together and with veins of the lower limb and vulva by the pelvic escape points, which you can see on the slide. They are located in the pelvic floor. If you have pelvic venous incompetency, it may lead to pelvic venous disorders, which may have a different clinical presentation. The most common are pelvic symptoms and varicose veins of pelvic origin. So let's analyze the pelvic symptoms. The most common is chronic pelvic pain, so the pain lasting for 6 months and associated with disability and required treatment. The prevalence varies depending on the study and geographic location. According to World Health Organization systematic review, the prevalence is up to 44% in 18 studies, including almost 300,000 women. Among the 3 high-quality studies with representative samples, the rate was 2 to 24%, and according to up-to-date analysis, between 4 and 16%. Pelvic venous incompetency is responsible for up to 30% of chronic pelvic pain. This symptoms is very important from the gynecological point of view because 10 of all gynecologic office consultations are for chronic pelvic pain, as well as 20% of all gynecologic laparoscopies. 10 million women suffer from this condition, 7 million do not seek help, and 61% are found to have no explanation of their pain. Pelvic venous incompetency may also cause other symptoms which you have to keep in mind. Common are dyspareunia, postcoital pain, and different menstrual disorders. Dysmenorrhea of congestive type will usually begin up to 1 week before menses. This is very similar to dysmenorrhea of patients with endometriosis. Headache, fatigue, and insomnia may be due to general autonomic dysfunction. Anxiety and depression are also very common. We have to remember about the differential diagnosis of chronic pelvic pain. The most common are gynecological, gastrointestinal, and urinary problems. I will focus on gynecological causes. The most common is endometriosis, which I just mentioned before, which can be a concomitant disease with pelvic venous incompetency in 12% of cases. Also, pelvic inflammatory disease, adhesions, fibroids, uterine and ovarian disease may cause chronic pelvic pain. The basic tool to determine the etiology of chronic pelvic pain, especially gynecological causes, is ultrasonography. And in case of suspicion of pelvic venous incompetency, transvaginal and transabdominal or transabdominal duplex ultrasonography should be performed. Transvaginal ultrasonography helps to exclude other causes of chronic pelvic pain and also to confirm the presence of venous pathology. According to systematic review for pelvic congestion syndrome, a vein more than 5 millimeters crossing the uterine body and pelvic varicocele seems to be the most indicative. In transabdominal ultrasonography, ovarian vein of more than 6 millimeters and reverse caudal flow in ovarian vein have a positive predictive value. It also allows visualization and assessment of iliac veins and renal vein. Cross-sectional imaging may also be helpful in the diagnosis of pelvic venous reflux. As I mentioned before, up to 20% of all gynecologic laparoscopies are performed for chronic pelvic pain. We have to remember that gynecologic laparoscopy is usually done in Trendelenburg position with increased intra-abdominal pressure. Therefore, the veins usually collapse. But if we turn the head upright and decrease the insufflation pressure, a more accurate picture of veins can be achieved. These are photos of my patient with endometriosis and concomitant pelvic congestion syndrome. When the endometriosis is suspicious, very helpful may be the assessment of CA 125 level. Let's move to pelvic origin varicose veins, which may appear as atypical lower extremity varicose veins, typical saphenous truncal incompetency, or vulvar or vulvovaginal varicosities. Very often it's a combination of all these variants. According to the studies, among patients presented with varicose veins of pelvic origin, less than 10% have been reported to have pelvic symptoms. Vulvovaginal varicosities appear in up to 22% of pregnant women and up to 10% of non-pregnant. They are more often seen by obstetrician or gynecologists and vascular surgeons, mainly because women usually do not mention about them during the phlebological office, mostly because the embarrassment. They are also not visible in standing position during the examination. Vulvar varicosities mainly develop during the 5th month of the second pregnancy. The risk increases with the numbers of pregnancies, and they usually disappear spontaneously after delivery. But in 20% of cases, they persist postpartum and enlarge with time. They may be asymptomatic, but also may cause some troublesome symptoms. Usually, the subsequent pregnancies are accompanied with an early reappearance and significantly greater dilatation of the veins. We also have to remember that they may be associated with thromboembolic events and bleeding. So what is their origin? The vulvar varicosities may be caused by the incompetency of the internal pudendal vein, but one half is caused by the reflux in the external pudendal vein or peroneal vein from saphenofemoral junction and great saphenous vein. There is also a possibility of vaginal and cervical varicosities related with pelvic venous insufficiency, especially during pregnancy, and also pudendal hypertrophy accompanying vulvar varicosities. The atypical varicose veins of pelvic origin appear generally in 3.4%, but their prevalence may be higher during pregnancy. They result from the reflux transmitted through the pelvic escape point, which serves as a perforating veins. The most common is peroneal and inguinal point. Here you can see the 3 peroneal points, an inguinal point, and gluteal point. In case of typical saphenous-truncal incompetency, the pelvic vein reflux may be transmitted through the internal pudendal vein to the external pudendal vein and then to the great saphenous vein, and also via epigastric vein. That's why it's very important to visualize the saphenofemoral junction, as its incompetency can be the reason for vulvar varicosities, but competent saphenofemoral junction may suggest underlying pelvic venous incompetency. In case of pelvic origin varicose veins, transperineal ultrasonography for evaluation pelvic escape point is mandatory. Here you can see the peroneal point and the inguinal point in patients with groin swelling and thigh varicosities. As a combination of vulvar and lower limb varicose veins is very often diagnosed, pelvic venous disorders are an interdisciplinary problem, and good cooperation of obstetrician and gynecologists with vascular surgeon and phlebologists is the key to the success. Thank you for your attention.
We deeply congratulate Professor Alexandra Jekurowska-Kaczorowska. And now we start the word round. It is my huge honor to start once again from Egypt with a special person to me, a huge professional, Professor Rashad Bishara, the man who made possible together with Professor Tahad the realization of the LATAF project. Rashad, the mic is for you.
Thank you, Sergio, for inviting me to participate in this very interesting and important project indeed. I enjoyed your presentation, Dr. Alexandra. Dr. Alexandra has nicely demonstrated the pelvic venous anatomy and the pathophysiology of pelvic venous incompetence, which is very interesting. As you mentioned in one of your references, that 62% of the patients who have pelvic venous reflux also have varicose veins of the lower extremities. And my question really is the same question that Sergio addressed to Professor Wool. Do you think that obliterating this reservoir of varicose veins would reverse or improve the pelvic venous reflux in terms of symptoms or in terms of pathophysiology? Thank you.
Thank you very much once more for the invitation, Sergio and Zaza. It is very interesting questions, and unfortunately I couldn't find any information about the impact of the treatment of varicose veins on the pathophysiology of pelvic veins. But according to the pelvic venous incompetency, we have to remember that even if we have the incompetency, it usually doesn't require treatment, as many patients are asymptomatic. And also, it is a very common finding after the second pregnancy. Also, in case of pelvic origin varicose veins, according to the studies, we have to remember that less than 10% of patients have been reported to have pelvic symptoms, as the pelvic reflux is compensated. And in such cases, usually the minimally invasive treatment from below, so sclerotherapy or phlebectomy, is usually sufficient and have very good results presented in the literature. According to, for example, to Gavrilov's study, he got a consistent therapeutic and cosmetic effect in 83% of patients after sclerotherapy, and there were no recurrence rate after vulvar varicose veins phlebectomy up to 8 years. There was also another study presented by Delfrate, who did surgical ligation of pelvic leak points, and he got only 2.2 recurrency after the procedure. And also in this Giannesini Sergio study, it was published in Phlebotomy, he also noticed that the improvement after sclerotherapy, only varicose vein sclerotherapy, was high, and it was noted only almost in 80% of patients. And I also analyzed the studies on disappearance of vulvar varicose veins after embolization. And you can see that the study usually failed to demonstrate the significant improvement in lower extremity varicose veins. There was, for example, one study presented by Hartung, and he found mild or moderate improvement only in 50% of cases, and none had a significant improvement. Another study, Kasten-Miller, has shown that the lower limb disappeared only in 14% of cases after embolization. Also, looking at the recurrency, you can find that the results are contradictory. In one study, Creton, he presented that the recurrence rate was in 54% of cases, but in another study, it was only 4%. It was presented by Greiner. So this topic is still unanswered, but I think that we can still go for treatment from below, especially in patients without pelvic symptoms.
Thank you, Rashad, and thank you, Alexandra, for a second lecture, basically, with this answer. And we fly now all the way to Mexico, thanks to Professor Zaza, who will introduce the next keynote speaker.
Thank you. I want to introduce Dr. Valente Guerrero, an eminent professional from Mexican Venous Forum. And I introduced the invite here to present his question.
Valente, unmute yourself. Okay.
Yes. Okay, thank you. Thank you again for the invitation. And before a really masterful conference, very rare are the doubles that personally remain. For many years, I have carried out the treatment for varicose vein in this area by means of with sclerotherapy. It draws my attention that despite not treating the points of the hypertension or escape point, the result of the treatments of the varicose veins in infragluteal region and thigh is so good. I mean, a good result that the varicose veins and many of the discomfort disappear, and even more, that the effect lasts for a long time. The question is because you think this happens. Again, congratulations for your excellent talk. Thank you.
Thank you, Valente.
Thank you. Thank you very much for that question. I also agree with you, and usually when I have patients with pelvic origin varicose veins, even if it's a vulvar or lower limb varicose veins, I usually perform the treatment from below because as you just said, usually the symptoms improve, especially when the patient doesn't have pelvic symptoms, and they usually do not have the pelvic symptoms. So definitely I would go for that. Why does it happens that it doesn't appear that they have recurrency so early? I don't know, maybe because you close the leaking point and that is the reason.
but I didn't find any reasons in the literature. That's my suspicious.
Thank you so much, Valente. Thank you so much, Alexander. Now we fly all the way to Ecuador. I wish it was me introducing him because he's a dear friend, but it will be Professor Willici introducing the next keynote.
Next, we have someone all the way to the other side of the Atlantic, the president of the Pan-American Society of Herbology, Professor Ernesto Intriago. Ernesto?
Thank you, Dr. Sasa, for the invitation. Congratulations for your brilliant presentation. Pelvic venous pathology is every time
Dr. Intriago, please.
Diagnosed better. Many
Dr. Intriago,
times
please change your language to English.
With organs what delayed is treatment.
Ernesto, there is an issue with your translation. You have to go in the channel. Khaled, can you guide him into the channel?
Dr. Intriago, please go to the English channel. Please change your language to English.
Oh, moment, please. Sorry.
Just don't pick up Russian, Ernesto, because that would be difficult.
No, please. No, tengo problema de conexión.
No, we can hear you. You just have to you just have to choose the language. Khaled, should he choose English, right? If you're speaking in English, Khaled, if you're speaking in English, Ernesto.
Sorry.
Okay. We can move meanwhile. While you're getting ready, Ernesto, we are moving to the next question, and then we'll go back to you so you can choose your language. And it is my huge pleasure to introduce Lika Ivarezhvili, and Zaza eventually can correct me in the pronunciation, of course, another representative of the Georgian Society of Angiologists and Vascular Surgeons. Lika, welcome, and your question, please.
First of all, I want to tell that the Georgian names, it was a lot of difficulties for Sergio. Mazarashvili, he knows approximately 1 year.
It took me 1 year, yes.
I want to introduce my old friend, Dr. Lika Ivarezhvili. She's radiologist working in gynecological hospital, and in Georgia she's most experienced for diagnostic of pelvic venous disorders. Lika, please.
Good evening, colleagues. Can you hear me?
Yes, perfectly.
Yes. First of all, I would like to thank the organizers for the opportunity to participate in this meeting. Many thanks to Dr. Alexandra for such an interesting and comprehensive report. My question to you, Alexandra, is how common are the ultrasound findings of polycystic ovaries and endometrial hyperplasia in case of pelvic congestion syndrome? And what's the approach of gynecological management of the patients with these conditions? Thank you.
Thank you very much for that question. It is true that in patients with pelvic congestion syndrome have more often cystic changes in the ovary and often also thicker endometrium than healthy women because of congestion and, first of all, estrogen overstimulation. We have to remember that estrogen is a potential vasodilatator. It causes nitric acid secretion, which causes the relaxation of the smooth muscles via stimulating nitric oxide synthase. It also causes pain, pelvic pain. And it also has an impact of a gynecological disease, such as you asked, polycystic ovaries. So according to the studies, the frequency of the polycystic ovaries is around 40% in patients with congestion versus 11% with no congestion. So it was reported by Park. But according even to the International Pelvic Society, it's even more. Up to 56% of patients may have an ovarian cyst. I also found another studies on that, according to which the
frequency of the ovarian cyst was about 10% in patients with pelvic congestion syndrome, and it was similar to the patients who doesn't have pelvic congestion syndrome. So the results are contradictory, and we have to be careful with the diagnosis. And the same situation is with endometrium. In the most cases, the endometrium hyperplasia results from the higher level of estrogen. So it's because of the overstimulation by the estrogen, which is combined with an insufficient level of progesterone-like hormones, which smaller the results of estrogen proliferation. And of course, in the ultrasound studies have shown a significant increase in endodermal thickness in pelvic congestion syndrome. I would prefer to say the endometrial thickness than hyperplasia, because according to classification in premenopausal women, so the women we are talking about when we are thinking about pelvic congestion syndrome, normal endometrial thickness is less than 15 millimeters. And according to the studies on congestion and endometrial changes, the endometrium thickness was 9 millimeters or 10 millimeters. Of course, it was significantly thicker than in normal patients, because there it was 6 millimeters, but it's usually not a hyperplasia, but a thicker endometrium.
Thank you so much, Alexandra.
And also support the statement that it's stimulation. And what is the approach? Of course, the suppression of ovarian function, so the progesterone therapy, it also helps in hyperplasia. Of course, we have to be careful if it's simplex or atypical, with atypia or without atypia. And of course, also with the polycystic ovaries, we also use progesterone. It also is helpful in pelvic congestion syndrome. As you know, that medroxyprogesterone, acetate, and implantation of beta-nogestrel or goserelin treatment may be helpful in pelvic congestion syndrome as well.
Thank you so much, Alexandra. Now, Ernesto, are you ready with your question in the channel?
Okay, thank you, Sergio. Congratulations for your brilliant presentation, Dr. Alexandra. Pelvic venous pathology is every time being diagnosed better. Many times it's confused with problem of the pelvic organ that delayed its treatment. I completely agree with you that this must be treated by a multidisciplinary team to obtain the best results. My question is, do you recommend starting with venotonic treatment or hormonal therapy and elastic compression before beginning an embolizing treatment? Thank you very much.
Thank you, Ernesto, and a very quick answer, Alexandra.
Of course, everything depends on what kind of symptoms patient has and on their severity. If we are talking about chronic pelvic pain related to pelvic venous incompetency, especially if the symptoms are not severe, I usually start the treatment with venotonic and hormonal therapy before embolization, which can usually be done if the pharmacological treatment fails. I think we have to be very careful when we are referring patients for the embolization. And I think that should be a really strict criteria when we should do so. As in my opinion, it's very often overtreated because, and we have to remember that our patients are very young. And according to the definition, we have to remember that it must be pain lasting for 6 months, which is associated with disability and which impair the patient's life. So in such cases, of course, the pharmacological treatment may not be sufficient, and we can perform the embolization. I have also sometimes patients with which has a bigger pain, intermenstrual pain, usually in the middle of the cycle, or dysmenorrhea, which is connected with a pelvic venous incompetency. And in that case, they also very well respond to the hormonal therapy. And in case of varicose veins of pelvic origin, my strategy I just said before. So if we don't have pelvic symptoms, I treat the varicose veins. And if they have symptoms connected with the leg, I use, and they do not want to have their varicose veins done, I prescribe venotonic treatment and compression therapy.
Thank you so much, Alexandra. Thank you again to all the key opinion leaders involved, Professor Bishara, Professor Guerrero, Professor Intriago, and Professor Ivarashvili. I will look forward for being in Georgia once again and learn how to pronunciate it properly. Unfortunately, we have no time for the question from the audience, but I will mention once again Jan Sweritz, who was giving the best question in terms of the likes. That is about the diagnosis of pelvic veins plexus thrombosis. What are the symptoms and how to diagnose it and treat it? So I will actually answer to this question next week, because indeed I will cover this topic in a talk of mine, because last October, there was a publication that is very interesting, reporting a 3% of uterine veins plexus thrombosis in the general gynecological population. So among all the patients going to the OBGYN, 3% actually has an incidental finding of uterine veins pelvic thrombosis. For this reason, I will cover this topic next week, and I ask you for some patience, and we will cover this next week. We deeply thank once again Professor Jekworowska, and now we move toward a very important moment for us, because a thing that we are maybe missing with the online initiative is reaching out to the audience. For this reason, also in the previous initiatives, we welcome evidence-based comments from the audience in the previous days before the events, and we selected the best ones. In this case, it is our huge honor to introduce Preeti Sharma, a colleague from the Care Hospital of Hyderabad, India. She sent a very interesting comment on the pelvic venous disorder scenario in the real world. Here, her comment is, and then we will have Professor Lazarashvili making a question to her.
Hello, everyone. Respected seniors and my dear colleagues, warm greetings from my country. Today, I will be doing a brief comment on real-world scenario about pelvic venous disorders. A study was done in 1999, about 20 years ago, which suggested that the prevalence of pelvic venous disorders in India is about 5.2%. Thereafter, there have been no global studies to estimate the prevalence. So the number of patients or the kind of patients that we see in our clinic is just a tip of the iceberg. Major hurdle is that these patients have different kind of symptoms ranging from chronic pelvic pain, atypical varices, leg swelling. And that's why we are not able to pick these patients at the right time. These patients also end up doing a lot of doctor shopping. They can meet gynecologists, urologists, spine surgeons, orthopedicians, and if they are lucky enough, they can meet the phlebologist or the intervention radiologist at the right time. But by the time they arrive at a diagnosis or the possible treatment, their patients are actually financially drained out. So the need of the hour is to educate and create an awareness among the healthcare providers themselves. This can be done by creating a society which has an integrated multidisciplinary approach. And we should make sure that in all of our national and international conferences, this topic is being dealt in detail and highlighted. The way we have to create awareness among the healthcare providers, we also have to educate and make the common people aware about the symptoms related to this and the available treatment options by creating an awareness drive. We are in the process of doing a pilot project wherein we will screen the government medical college patients, arrive at a clinical diagnosis using minimally expensive tests, and suggest them affordable treatments. Thank you.
So we deeply congratulate Dr. Preeti Sharma, and indeed we will give her the honor of having the project leader, Professor Zaza Lazarashvili, making a comment to her. But before, I'd like you to introduce yourself, Preeti. Here you are. Welcome to the stage. Really nice to have you with us.
Yes, thank you. It's really very important project. I'm very satisfied that young doctors started so difficult work, and I have very short question because the awareness of between the population is also of course very important, but for today it's more important. Most important is the awareness and to create the unified language between the different doctors from different specialties. And my question is to if they have the some agreed protocol between the doctors who that the acceptable for both for gynecologists and vascular specialists.
Yes, sir. I'll just brief you about the pilot study. And what we have done is we have spoken to the medical college head of the department gynecologist now, and we have made a draft of a tentative protocol in which we will follow and do a kind of pragmatic study and see how we can get it maximum output, because these colleges or medical colleges have their own challenges. They see around 100 to 150 patients one day in their outpatient clinics. So we have drafted a protocol which is with they will have minimum questions to be asked and minimal findings. After that, they will be referred to me and my radiology clinic, radiology colleagues, and then we will screen them for whatever the cause, if we can find out if there is any reflux or incompetence. So basically, a temporary draft has been made and it has been an agreed protocol between the gynecology colleagues and me.
Thank you so much, Preeti. We look forward for meeting you in person. I'm sure it will happen as soon as possible. And now it's time to wrap up the session. And of course, we have our honorary chairs. We couldn't go higher than with Professor Julianne Stolten, a wonderful professional, wonderful human being from Harvard University. Julianne, can you tell us what are the take-home messages we should take home indeed?
Sure, I'll try to go quickly. Good morning, good afternoon, good evening to everyone, and hello from Boston. I just want to thank Sergio and the committee for asking me to say a few words as well for this phenomenal program. I first want to just shout out and commend Dr. Uhl for his meticulous and detailed work outlining the anatomy of the pelvic venous system and the many complex interconnections. I remember looking at his diagrams many years ago, and this important work helped me to gain a much better understanding of the relationship between the different venous systems. And I think every time I listen to your talks, I learn something and discover something new. Thank you for your work and for sharing this with the world, and I hope we all appreciate that, and thank you. Our next speaker, Dr. Lazarashvili, you did a wonderful job outlining the difficulties that we have, the definitions, the terminology. I think we all really need to learn to speak the same language. And I commend you on the algorithm at the end of the talk, which really summarizes the venous disorders. I think I'd like to see us speaking that language, using that kind of overview algorithm, and make sure we can put the patients in the right buckets, as Dr. Meisner would say, to make sure that we get the best outcomes. So thank you for that. And then Alex, Dr. Jawaruka Kazarowska, I feel like your talk was a perfect addition to this session. This is one of the biggest hurdles we have, taking care of patients with chronic pelvic pain. As vascular specialists, we tend to see and hear only the symptoms that we want to see or hear about venous disease, but we really need to know and understand the etiologies, the other etiologies, and how they can complicate and affect our patient's course. And one of the biggest take-home messages I would say is we need to work together with the other specialists, as we've all been saying. Many of the patients can present with a combination of these disease entities, and we need to know how many of these symptoms how many are really from the venous pathology. So I've started to work very closely with our gynecologists. Most of the patients get a full workup and GYN exam, and we start with the medical treatments and sometimes laparoscopy to rule out and treat endometriosis or other diseases before I fix their veins. I think it's just best because these veins could be just incidental findings that have nothing to do with their actual pain. So I think the patients appreciate the caution and the wisdom of this approach, and we don't want to go to the procedure room to close veins down that are narrowed, or open veins, or closed veins that are refluxing, or open veins that are narrowed. We don't want to do that if that's not the real cause of their pain. So again, thank you. I think we all need to be experts in this field. We need to understand the complexity of the anatomy, to speak the same language with consistent terminology, and to work closely with a multidisciplinary team. So that's going to be the best outcome for all of our patients. Thank you again, and I congratulate Sergio, Willie, Oscar. Thank you for this wonderful program, and I look forward to the rest of them.
Thank you so much to you, Julianne, for always being one of the brightest lights to follow in the field. And in this field of pelvic venous disorders, indeed, we are also touching the gender equality a little bit. So indeed, we will finish on February 14, Valentine's Day, because everybody knows about the male varicocele, but very few people knows about the female varicocele. So it makes total sense to have two huge eminent figures in the field, one Professor Stoughton and the other one Professor Louis Altarazi from Lebanon and Syria, to give us the final remark as well. So Professor Altarazi, would you like to speak live or do you want us to play the video?
Play the video, why not?
Okay, so I will go with the video. Here we are.
Hello, it's my great pleasure to participate in this extraordinary POB initiative. Dr. Zaza, thank you for your rational presentation and also for all your work in our working group. Pretty Alexandra, I enjoyed a lot your throughout comprehensive gynecological point of view presentation, really. Jean-François, chapeau et félicitations. Every time I follow your work, I am astonished and I learn a lot. As our team is working with this pathology since more than 20 years now, and even with thousands and thousands of cases, we know that we learned a lot, but we still have more to learn. This pathology have a lot of unknown aspects and unreported aspects. So let me present to you our series of short video lessons called Pelvic Venous Disorder Unreported. So I uploaded to you a presentation about male pelvic congestion syndrome with all its extraordinary manifestation and communication in today's video lessons. Please look at it. And in the near future and in the other webinars, I will upload to you other subjects like anatomy, variation, and anomalies. There is a lot of anomalies that we must know. Also, we'll talk about neuroskeletal pain, sciatic vein repermeabilization, hip joint venous congestion, piriformis, and psoas muscle syndromes. And we must show you our technique of pushed foam sclerotherapy. As with this technique, you can, with one series of injection, mainly in the ovarian vein, close the pelvic vein, the escape point to lower limbs and vulva. And sure, we must present the technique complication, thromboembolism, perforation, catheter migration. We must know them and be well equipped to deal with them. And after that, I'll try to send you successively the other short video lessons concerning this pathology that is still unknown, finishing, but what have we learned? What should we learn? So let me at the end thank Sergio for his effort and all my companions during these 20 years, beginning by Dr. Mondero, now finishing by Dr. Labropoulos, and all of you. Bye-bye.
Thank you so much, Professor Louis. Would you like to have a brief comment live?
Yes, so now I think the symptomatology and the indication have changed. Because it is not only the pelvic pain and the lower limbs pain. We know now that hemorrhoids, that male impotence, that sciatic pain, psoas pain, and a lot of other symptoms may be in the symptomatology. So we are treating more and more patients with this symptomatology. Thank you.
thank you so much. I'd like to deeply thank once again Professor Stoughton and Professor Altarazzi. With this, we finish. I will have to learn how to say grazie in Georgian, brogabda or something similar, but I have other 3 webinars to take lessons in Georgian. So I would have liked to have Oscar with us, as always, our honorary president, but he's having connection issues, as you can see from the picture where he is. So we will have in his place another family member, Professor Simkin Roberto, giving a final word. Roberto? Unmute yourself. You're muted, Roberto? Okay, good.
Yes. Do you listen me?
Yes, good.
Yeah, okay. Oh, all the conference are very, very good. This topic is very interesting, and it's very interesting. Continues with study in this topic for in all the world, like you put in this important symposium. Thank you very, very much for the kind invitation to participate with very important speaker in all the world. Bye bye. Thank you very much at the other opportunity.
Thank you so much to your representation of all Latin America. Willie, your time to say goodbye.
Dear friends and colleagues, see you next week.
Thank you for recovering that time. And then we have Zaza with us in representation of all Georgia that you can see in this picture. That is truly a spectacular place. I encourage you to visit. Zaza?
Thank you to all. Thank you to our honored guests and to all the speakers and panelists. And see you after 1 week on 1st of on January. At the end of January, we will continue this webinar cycle. Thank you.
Thank you so much, Zaza Salvatore Lazarashvili and Nodir Georgian Association. Thank you so much to the stellar faculty of today. Thank you once again to the unbiased support of Alpha Sigma who made it possible. And thank you to all the ones who have joined in person and online. This was actually happening exactly 2 years ago on the Italian Alps. This night we were 2 years ago on the top of the Alps skiing together. I look forward for being together skiing on the dunes and of course, even before COVID allowing, of course. So stay safe and see you next Sunday. Thank you so much to all the ones. Bye.
Thank you. Bye.
Thank you. Bye-bye.